All right, any questions before we get started on this while people are logging in? I forgot to bring my joke book with me, but that's okay. I have one in reserve. This is actually an international joke. I have a coworker of mine who is Egyptian, and her Egyptian husband told her this joke, which I thought just goes to show you how international humor can be in certain life situations. So there was a detective. He was responding to a call. Apparently at this house, a wife had just killed her husband, and so he gets to the house. Gets to the house, and there's all these policemen. They're outside the house, and they're all waiting there. And he goes, "What's going on? Is the woman still in the house?" And they go, "Yeah, she's still in there." He said, "What happened? Why'd she kill the guy?" She goes, "Well, because he stepped on the floors when they were still wet after she had cleaned them." I'm like, "Oh my goodness." They're like, "Well, why aren't we going in there? Why don't we go get her?" They go, "We're waiting for the floors to dry." International lesson: don't make your wife mad. And have a much happier life. Anywho. I do like how Kahoot updated their little thing there. It's cute. Let's hope you're not haunted by a bad grade. Not spooky.
Have you heard this one? After you die, what part of your body is last to stop working? Your pupils, they dilate.
Pretty good.
It wasn't mine.
What was the pet name that the ghost had for a significant other? His boo. Okay. You guys ready to begin? I'm noticing some people are late to log in, but please do so. The pin will still stay up there. We're going to get started. All right. The first question, 25 questions, yes. Which dosage form would be most occlusive if you were applying this topically? Be an ointment, a gel, a cream, or a lotion. Can everyone see the answer choices? Should I raise that up some more? A little further. What do we think? When I say occlusiveness or occlusivity, what do I mean by that? Yeah, how long does it stick around for, right? Very good. Yes, the ointment would have the most occlusiveness associated with it. Why would that be? Is it more water-based, oil-based? More oil-based. Usually it's going to be like a water and oil emulsion, so it sticks around. So you think like Vaseline, how it has that kind of gross, greasy kind of feel left behind. That's kind of what you're looking for because it leaves a nice layer behind of the medication, better contact time, better absorption potentially, right? Versus the other ones tend to be more what-based? Water-based, or it could be alcohol-based. Yeah, so some like certain gels might be alcohol-based. That tends to do what to the skin? Dries it out a little bit more because that evaporates and will get rid of a lot of that moisture. Very good. Okay. I guess a Galaga monster. I don't know what. Asteroids perhaps. Which of the following would be a reasonable treatment for rate control of AFib? It'd be diltiazem, nitroglycerin, adenosine, or lidocaine. What do we think? Be rate control for AFib. I hate the sounds though. I'd rather listen to you all. I'll beatbox for it.
Okay, go ahead.
Nah, I don't want to embarrass anyone. And get your answers in. Moving on. I don't know who does that to you. But anyway, yes, good. Diltiazem, right? Because what class of antiarrhythmic is diltiazem? So not DHP, what class antiarrhythmic? It's 4, right? So how is it working why do we consider it rate control? Because slowing down conduction from SA AV node down to the ventricles, right? So even though you have a rapid atrial rate, it's getting slowed down such that it does not communicate with the ventricles, right? So atrium may not be all that efficient, but the ventricles still can be because they're still getting a relatively controlled rate there, right? In terms of rhythm control, what would be an option here? Amio would probably be a good option there, potentially. Would nitroglycerin fit that bill? Nah, wouldn't do anything. How about adenosine? Maybe, but that was more like an SVT sort of situation, right? AFib, not typically, you're going to see adenosine being used there. And lidocaine, where do we like using that? Yeah, so maybe as a backup to amio, but typically like for MIs, again, because what classification did lidocaine fit into? So class 1, A, B, or C? B. It's a class 1B antiarrhythmic, so it works on which channels? Sodium, but primarily where do the 1Bs like to work? In ischemic tissue, right? So again, it was working well in like ventricular arrhythmias caused by MIs potentially, right? So that was where those tend to have a little bit better activity there, okay? Very good. Moving on. It's my favorite story. For arrhythmias, beta blockers are considered. So it's kind of going along the same route, so it's good that these are paired together. It'll be rhythm or rate control. So one should be easy. What class are the beta blockers?
2.
Class 2 antiarrhythmics, absolutely. What's a notable exception though? Which one fits into the class 3 antiarrhythmics? Sotalol, very good. Why does it do that? It blocks potassium channels. Good, so that still fits into the class 3 antiarrhythmics. Very good. Most people have answers, so I will skip ahead. That again would be rate control. Good, because again, slowing down conduction between the SA and the AV node down into the ventricles. Very good. So I could have put a beta blocker on that last question, and that would have been correct too, right? That would have been totally fine for AFib. Very good. Who would I want to be careful of using beta blockers in? They have heart failure, absolutely. Who else? They have like asthma, particularly if it was like a non-specific beta blocker. What's a good example of a non-specific? Pranolol, Nadolol, Pindolol, anything N through Z, right? Absolutely, very good. All right. Let's see. Which med would have the fastest onset for treating all symptoms of anaphylaxis? It would be sodium chloride, diphenhydramine, methylprednisolone, or epinephrine. What do we think? The patient comes in, they say, I found a peanut in my salad and now I can't breathe. And they go down. What are you going to give them first? Very good. So epinephrine, yes. So how does epinephrine work? Bronchodilation, good, by acting on which receptors? Beta 2, good. So it acts on beta 2 receptors. What else does it do? Vasoconstricts, good, by acting on alpha 1, good. What else does it do? Decrease or increase heart rate? Increase heart rate by acting on beta 1, right? So beta 1 receptors would be stimulated there as well. Now, these patients, are they typically tachycardic to begin with? Why? Because one, their body's trying to release its own sympathetic, or it's trying to activate its own sympathetic nervous system, releasing norepi and some epi right from the adrenal glands. Why else? They're scared, they're anxious, good. What else? Their blood pressure is typically low, good. So then, because SVR is down, cardiac output needs to go up to compensate, lest they get tachycardic, okay? So how could we treat that? How can you treat the hypotension besides just the epi? Good fluids. So we use isotonic fluids such as sodium chloride. What percentage is isotonic? 0.9%. Anyone know the sodium concentration in that? 154. Yeah, 154 milliequivalents per liter. Good. So if you had half normal saline, how much would that have? 77 milliequivalents per liter, right? And that would be what percentage? 0.45%, right? If you had quarter normal saline, gets too hard at that point, right? It's like 30, yeah, in the 30s somewhere, right? And then that'd be 0.22% typically for quarter normal saline, right? So you're not going to use that too commonly in practice, but certainly half normal saline, you're going to use all the time, certainly. Okay, good. So that would help out with the hypotension. What dose would you give for the fluids? So that's for maintenance fluids, would be the 4-2-1 rule. But to start out with, in terms of getting that volume back up, 20 ducks, 20 milliliters, right? It's a fluid, so you're dosing in milliliters, not in milligrams. Milliliters per kilogram of the patient, right? So if you had a 50 kilogram patient, they would get 1 liter. Yes, ma'am.
Did you say there was a point that you kind of like stopped at?
Yeah, most pediatric patients, you normally cap it off at around 1 liter. Adult patients, you may do between 1 to 2, but that's just a starting point, right? You can always give more fluids. It's hard to take it back. So the patient may need 6 to 8 liters potentially, but you can gradually give that, right? Most of your orders are going to say give 1 liter, give 2 liters, normal saline IV, either with a pressure bag or hang it to gravity or whatever, however you're going to get it into the patient, right? Very good. And so that would work pretty quickly. How about the diphenhydramine? What's that going to do for us? Well, how does diphenhydramine work? It's an H1 antagonist. Good. So it's blocking the effects of histamine, which are doing, what's it causing in? Yeah. So it's coming from the mast cells. What's it doing in the body? Causing the bronchoconstriction, causing the hypotension. That's what the histamine is doing, right? It's causing all the redness and the itchiness and all that stuff. So by giving diphenhydramine, it's going to help to reverse that effect. Is that pretty quick? Pretty quick, yeah. So as soon as you give it, usually you're going to give IV doses. Maybe not as fast as epinephrine. Epinephrine is always going to be the life-saving thing you're going to give, first those really severe anaphylactic cases. But some patients may be managed just with diphenhydramine in some instances. How about the methylprednisolone? What's that going to do for us? Long-term control, right? Help decrease inflammation overall. So this is going to help for the hours to days period rather than working in the minutes period, okay? So again, if you're like, I got to get one of these medications on board right now for a true anaphylaxis, you're going to say Epi first, right? Then you worry about your fluids and your Benadryl. Now, frequently in an ER setting, you're going to have multiple things happening at the same time. You'll give out a list of orders, and you have people like nurses and RTs and things like that. They can all go and carry these things out in parallel. So it's not always like it's just like one thing and then the other thing and then the other thing. It's usually multiple things at once. Okay. All right. You were concerned for MRSA pneumonia in a patient. Which antibiotic would cover this? Azithromycin, linezolid, dicloxacillin, or daptomycin? Should be a good option here. You're like, wait a second. My obvious answer choice is not here. What do I do? The pharmacist calls and says we're on shortage. We don't have Vanco available. You gotta pick something else.
Dang, my perfect streak gone. Just like that.
But that pin code though, it's pretty good. It's got perfect 9s.
Yeah.
All right. Is your last answers in? And yes, linezolid was the correct answer there. Very good. So what would azithromycin help cover? In terms of pneumonia. Yeah, you think about your atypical bugs like your Mycoplasma pneumoniae, Legionella, stuff like that. What else does it cover? Strep pneumo, and we'll get some of those gram negatives like H flu and whatnot, right? Good. How about dicloxacillin? What would we use that for? MSSA, right? That's very specific. So if you had someone you were starting off on broad spectrum coverage and you've been narrowing it down based off the cultures and it said just MSSA, at that point dicloxacillin is probably going to be one of your best friends. Like nafcillin, oxacillin, any of those are totally fine there, right? Now linezolid is good because that will definitely cover MRSA. What else is it good for? VRE, very good. Or VRSA potentially you could use if maybe you started them on Vanco and came back resistant to that. Maybe that could be a good option there. How about Dapto? What does that cover? It covers MRSA, but does not cover pneumonia. Remember, it gets inactivated, so you never want to use Dapto for that. For a bloodstream infection, for cystitis, any of those would be totally fine there, right? Very good. What toxicity do you have to worry about with Dapto? Good, muscle toxicity, right? What would you measure to look for evidence of myotoxicity? California, Pizza kitchen, right? Your CPK is what your immunizer in there. Very good. What organ toxicity could that lead to if you develop rhabdo? Renal failure, right? That myoglobin is going to clog up the kidneys if it gets precipitated out, right? So that's the one thing you really want to be careful of. Any big concerns I would have for linazolid? Any drug interactions I'd worry about? It's a good thought. SIP is always a good thought. Not right in this case. SSRI interaction, right? This is going to have some monoamine oxidase inhibiting capabilities, right? So it's going to help to block breakdown of things like serotonin. So if you have a patient who's on, say, an SSRI, and we'll talk much more about that next semester, but you're going to see that could be a potential interaction there, right? Could lead to, what was that thing it could lead to? Too much serotonin? Serotonin syndrome, right? Sometimes they make it easy, right, for the names. Not always. All right, moving forward. Which medication would be appropriate for coverage against Pseudomonas and ventilator-associated pneumonia? The peptazo, vancomycin, ceftriaxone, or levofloxacin? All right, moving. There we go.
Okay.
There were two correct answers. You guys love it when I trick you like that, right? Let's walk through it. Okay. So looking at this, so peptazo fits in what category? The anti-pseudomonal penicillin. Very good. So it's a beta-lactam drug. Remember, when you're covering for Pseudomonas, you typically want a beta-lactam plus something else, right? That's the kind of like you double cover for. So peptazo. Very good option there for covering for Pseudomonas. Levofloxacin, which category does that fit into? Fluoroquinolones. Also very good in terms of coverage against Pseudomonas, although resistance may be a bit of an issue with that one. But who's to say? It's a good starting combination. A lot of patients will be put on peptazo and levofloxacin. What organ function I have to monitor for to make sure they're not going to be accumulating too much of the drug? Liver, kidneys? Kidney function, right? Kidney function is huge for most of the beta-lactams and all of your fluoroquinolones, except for, the exception for the fluoroquinolones. Which one can't you use for UTIs? Moxifloxacin, that one's in the liver, so that one you don't have to worry about renal function for. But all the other ones, because again, it's good to know the exceptions, all the other ones have to undergo renal excretion. And again, when you develop ventilator-associated pneumonia, you can develop sepsis. Guess what happens to renal function? Can decrease because you're hypoperfusing the kidneys. That's always a huge concern. You have to monitor that daily, right? You always have to go back and check their new renal function when you get the BMP back on them, right? Good. We know vancomycin would cover MRSA. Does it cover any gram-negatives? Negative, right? Negative for gram-negatives. Now, how about ceftriaxone? Third-generation cephalosporin. You know, it's funny, I was at Nemours yesterday, and I got a call from somebody, actually one of the technicians. They answer all the phones initially. It said, some lady's asking a question about antibiotics. I don't know what they're talking about. And I said, okay, I'll take it. And so I took it. And it said, hi, I'm a medical student. I was asking about X, Y, and Z. I was wondering about patients on ceftriaxone, but they wanted to transition to something orally. What could I do for them? And I said, oh, it's a medical student. I'm going to pimp them now, just like I would do with my students. So I said, oh, that's interesting. So what category of drug are they on right now? She's like, cephalosporin. I said, good. What generation? She's like, third. I said, yes, good. I said, what's an oral third generation you could use? Anyone know? Ceftenir, absolutely. Omnicef is a good oral third generation agent, right? So ceftenir. So she eventually came up with ceftenir. I said, very good. That could be an oral alternative. So you could actually transition someone to go home on ceftenir if they're on ceftriaxone IV, right? Very good. But does that cover Pseudomonas?
No.
Negative. It will not cover Pseudomonas. Very good. What would be a cephalosporin that would cover Pseudomonas? Cefepime, right? That's the main one we're going to be thinking about because that's the one we use most commonly, right? Again, there's others, but we will save those. Usually like ceftazidime is the other one, but we save that for very rare circumstances. Okay? Very good. If I'm covering for MRSA, how many drugs do I need to use that? I'd use to cover that. 2? 1. 1 drug for MRSA, 2 drugs for Pseudomonas. If you're going for that really broad coverage for healthcare associated or ventilator associated pneumonias, you got to go 2 drugs for Pseudomonas, 1 for MRSA, right? All right. Which medication has the slowest onset of action for chronic treatment of asthma? Would it be theophylline, omalizumab, albuterol, or mometasone? I tell you all, my 3-year-old now does this thing when she's like trying to pick out like a YouTube video or she's trying to find a shirt to wear. She'll go, what shirt should I wear? All right, what do we think? Very good, mometasone, right. So let's look at it. Let's think about mechanistically why some of these would be a little bit faster or shorter. So for instance, like albuterol, fast or short? Or fast or long acting here. Fast or slow, I should say, right? I'm not getting my adjectives correct, but fast or slow, there we go. That would be very fast, right? Because what does it do? Directly stimulates what? Beta 2 receptors, right? So it causes bronchodilation, right? So it's a very direct sort of action there. How about something like omalizumab? That's a monoclonal antibody. What does it bind to? Binds to some sort of antigen. What's the antigen for this antibody? IgE, right? It binds to IgE. Neutralizes it. Does that sound pretty fast? Do your antibodies work pretty fast? And you have something you're, vaccinated against, right? Yes, it works very fast. So omalizumab would be pretty quick acting, right? How about theophylline? That one we generally don't use for asthma too much anymore, but it has somewhat of a direct action. It antagonizes adenosine receptors, will inhibit phosphodiesterase. There's a myriad number of things that it does, but fairly fast acting in terms of that. But mometasone, what type of drug is mometasone? That's steroid, right? And what have we said about steroids? Especially with mometasone, because what route would that be given?
Inhaled.
I mean, inhale, right? So again, orally they're inhaling it, but we would say an oral medication because it doesn't really make sense that you're not absorbing it from the mouth. But yeah, it's an inhaled medication. How long could it take before you get full effects? Like a month, 6 to 8 weeks in some cases, right? So again, compliance is super important. They may not realize it's even working for several weeks before they get that benefit, so they need to stick with it, right? Which is why we frequently put steroid with what else? Short-acting or long-acting beta-agonist? Long-acting, right? So salmeterol, formoterol, something like that gets put in with one of those. So we get the immediate benefit of a long-acting beta-agonist, plus as time goes on, you get the additional benefit of the steroid, right? So you get better synergy by using the two together. Make sense? All right. Which patient would be contraindicated from receiving alteplase? TPA. Would it be someone who had a serious GI bleed 6 months ago, a shellfish allergy, pregnant patient, or blood pressure of 190 over 110? Did you hear about the clam that got sent home from middle school? Or maybe he was being shellfish. Should have said preschool, but. All right, what do we think? Put your answers in. And very good. So, looking at this GI bleed 6 months ago. It's too long ago, right? Not that big of an issue, right? So what's the time frame we're looking at? What do our slides say? A couple of months, right? 2 or 3 months, I believe. Right? Probably 3 months. 6 months would be too long ago, unless they're having some kind of ongoing issue that is predisposing to that GI bleed. We wouldn't want to do that. So that in that case here, and again, when you are going through and deciding whether to give someone systemic TPA, like say for a stroke or a PE, do you think you're just going to think like, okay, do I remember every single contraindication? Negative. You could kill somebody very easily with this drugs, which is why there are set checklists. You have a lot of people you're talking to make sure everyone's in agreement that when you decide to push that drug, that it is the right drug for that particular patient. Okay. Shellfish, while for some drugs may be a contraindication, if they have an allergy, could cross-react. This is not one of them. However, pregnant patients, why would that be contraindicated? Fetus could bleed too, right? You don't want that to happen. And then the blood pressure, what else? What could that lead to? Yeah, like cerebrovascular accidents could happen. Now, does that mean that there's nothing I can do about that blood pressure? What if I could give something to get that blood pressure down? Could I administer it then? Yeah, in those cases, yeah. Usually we'll give them 1 or 2 tries. We'll give them something like hydralazine or a ACE inhibitor, like an allopril IV, something like that, try to get it down. If we can get it under control, then we administer the drug. If not, then we say no go, right? Very good. Which chemo agent would lead to osteoporosis in female patients with breast cancer? Be flutamide, exemestane, doxorubicin, or raloxifene, I think. You guys need a Title IX reminder?
Huh?
You guys need a Title IX reminder? Number aspirin in class, please.
Yeah, this one I'm just like.
All right, what do we think? Transfers in. Very good. Okay, so let's look at it. Some of you. So let's look at our mechanisms of action of the drugs, right? Because again, going back to the mechanism, it will inform you about potential side effects in a lot of cases there, right? So for instance, like flutamide is what kind of drug? Anti-androgen. Now, would a patient with breast cancer need an anti-androgen drug? No, because those tend to be what? Responsive. It's breast cancer. What stimulates breast tissue? Estrogen, good. So those are typically estrogen dependent or estrogen responsive in some cases, depending on the subtype they have. So they would not need to be on anti-androgen, so we wouldn't have to worry about that for that patient there, right? Doxorubicin was what type of drug? It would be a good idea to know your different chemo classifications of medications and mechanisms. This is one of those anthracyclines. Remember they like to, one of my favorite words, they intercalate into the DNA, right? They also inhibit topoisomerase, right? So they're going to cause that DNA damage, right? Remember what color it is? Bright red, right? Especially when it gets into IV bag, or actually kind of a darker red, almost looks like a port, almost. What organ toxicity did I expect to see with doxorubicin? One cause cardiomyopathies, right? That's one that has a lifetime max dose they can receive. Okay? And remember the antidote, or the thing we give to prevent that myotoxicity, doxorubicin. Dexrazoxane was the one for that, okay? Those are good things to know about these drugs. Now, raloxifene is what kind of drug? So the SERM is the term we use for that. It's a selective estrogen receptor modulator, right? Which means in some estrogen receptors it works as an antagonist, and other ones it acts as an agonist. This is nice because it works as an antagonist in the breast tissue, where hopefully it will stop the cancer cells from growing, but it works as an agonist in the bone such that you don't have, because again, estrogen normally has what effect on the bones? Stimulates nice, strong, dense bones, right? That's why people who undergo menopause, they lose that estrogen, they end up developing osteoporosis, right? So if I give them drugs to block estrogen, guess what? You're going to get the same effect. But raloxifene is nice because it works as an agonist in that bone tissue. Okay, good. Now, exemestane, anyone remember what this did? It's actually in the brand name. Aromacin sounds like aromatase, which does what? Converts testosterone into estrogen. Remember, you can drop estrogen levels quite significantly by using something like exemestane. That would definitely lead to osteoporosis in those female patients, right? But again, use it for those more treatment-resistant types of breast cancer where you just absolutely have to get rid of the estrogen, all the other side effects, you know, it's a way in risk versus benefits, and those are otherwise for more treatment-resistant patients. Okay? All right, very good. Which of the following inhibit DNA synthesis by acting like a false nucleotide? Would be methotrexate, etoposide, docetaxel, or cytarabine. I can tell the cancer stuff is stuff that will be reviewed heavily after today, correct? This is the whole point of the reviews though, right? You figure out where your weak spots are.
It makes sense. We haven't had it at CMS, and we've had all the others.
Tis the nature of the beast, unfortunately.
It is.
We try our best, but
You can't teach everything before everything.
yeah, it'd be nice if we could do it all at the same time, but
You can't go to school uphill and go back to home uphill. Unless you're my parents.
okay. Yes.
You've heard the adage, right? Walk
No, it was
school-
fun. I had a lot of fun in
walk
school.
School uphill both
Yeah.
ways.
You guys have it hard. You guys have it all smooshed into 27 months. Okay. Well, let's look at the drugs here, right? Okay, so let's go through it one by one. Methotrexate, how's that working? Folic acid antagonist, right? Prevents the cycling of folic acid such you cannot produce new nucleotides, right? So you can't produce things like thymidine because the folic acid necessary for that process is being interrupted by methotrexate, okay? We'll talk a lot about that in the rheum section next semester for sure, but here we're talking about in terms of its use for cancer. Good. How about things like etoposide? That would work. Going to be one of our microtubule active drugs, right? Remember we talked about there's like the vinca alkaloids. Also talked about like etoposide, tenepicide. Those are working on the microtubules. Preventing those from working, you arrest what? Mitosis, right? You cannot undergo mitosis at that point. And how about docetaxel? Remember that? It's another topoisomerase inhibitor, right? So very good. Cytarabine though, Ara-C, that one's going to be that false nucleotide, right? So once it gets incorporated into the DNA, it cannot propagate any further, right? You call that chain, we call it terminator, right? It's kind of like the Arnold Schwarzeneggers of drugs, right? The chain terminate. You cannot do anything further. It's not a very good reference, but whatever. Get the point. So again, good. Know your mechanisms, know the side effects associated with these, especially any kind of unique ones, right? Those are good things to know. In particular, drug interactions that come up, those are things. Because I'm not going to ask you, a patient presents and you diagnose them with a certain type of leukemia, what's the drug regimen you're going to go with, right? That's outside of our scope. I'm not going to ask you those kind of questions. But focus on the actual facts of the drugs. I was right. Which of the following would provide coverage against Legionella? Be clindamycin, azithromycin, amoxifloxacin, or cefazolin. First the question is, what kind of bug is Legionella? Could be hiding in our air conditioner right now. We would not know it. Waiting for his chance to strike. All right, get your answers in. All right. Two correct answers here. Right, so we said Legionella is a what kind of bug? Atypical, very good. So what does clindamycin cover? Anaerobes and gram-positives, very good. How about cefazolin? Kind of wide spectrum, right? You'll get MSSA, you'll get some gram-negatives, some gram-positives, right? Does it cover atypicals though? Nah, cephalosporins aren't really good for covering atypicals for the most part, very good. So what other classes do we have? Well, certainly the macrolides will work, right? Those will cover atypicals. This is usually the most common thing we'll go with. And the fluoroquinolones will certainly do that as well. Are there any other classes we've talked about? Tetracycline's the other group, right? So like doxycycline, tetracycline, any of those would be totally fine to use additionally, okay? Those are kind of your three main classes we talked about that are really good for getting those atypical bugs. Very good. What would I have to worry about in terms of, say, EKG changes? Either like a fluoroquinolone or a macrolide. Was that? QT prolongation, good. What sort of antiarrhythmics would interact with that pretty significantly? Class 3 most likely, right? So class 1 maybe could have some interactions for sure, but class 3 would be more likely because, again, how do these drugs cause QT prolongation? They block potassium channels. What did class 3 do? Block potassium channels as well, right? So direct interactions there. So something like, what would be a good example of a class 3? Amiodarone, what's another example? Try about one other one, I think. Mentioned sotalol, what else? The phetylide's the other one. Ticicin, right? That's another one that's a good class 3 agent there that would certainly lead to QT prolongation, could lead to odds, and you treat that with magnesium. Absolutely, very good. All right, what's up next? Which antidote drug combination is correct? These are my favorite questions. Would it be folinic acid and methotrexate, mesna and cisplatin, acrolein and cyclophosphamide, or dexrazoxane and vincristine? We're actually on national back order of vincristine currently. Actually, that's something we had to deal with yesterday.
I remember you talking about this answer. You tend to do that. You tend to talk about the material.
Weird.
These questions. Bold statement. I'm just coming out here with it. Yes.
Controversial statements from Cam today. Very good. Yes. So remember, methotrexate works as a folic acid antagonist, so it would make sense that instead of giving folic acid, which would be useless in the face of methotrexate, what we do is instead give the activated form, which is folinic acid or leucovorin, right? Sometimes you see those leucovorin rescues you can give in order to help to try to replenish healthy cells with folinic acid, to utilize it in order to help prevent methotrexate toxicity, right? Mesna would be good to go with which agent? Good question. Well, cisplatin is which category? Anyone know? See plat, so you know platinum's in there. It's a platinum-based alkylating agent. There's not really a whole lot of good antidotes we have for those for the most part. So mesna is instead, you're actually going to work with cyclophosphamide, because cyclophosphamide produces acrolein, which causes hemorrhagic cystitis, right? So we give this along with mesna, it'll bind up the acrolein to prevent that hemorrhagic cystitis from occurring there, okay? Now we mentioned dexrazoxane already. That works for which group of drugs? It's going to be our doxorubicin, daunorubicin, mitoxantrone, right? Those are the anthracycline drugs that would work for it, right? That helps to work as a cardioprotectant, helps to basically, or works as an antioxidant and a chelator against those free radicals that are being formed by the anthracyclines, right? Now vincristine falls in which category? The vinca alkaloids, right? Those are again working on the microtubules to help prevent that mitosis from occurring in those cells there, right? Which agent here listed could be fatal if administered intrathecally on accident? Vincristine, right? Good. Which one of these would cause a peripheral neuropathies? Most commonly, you probably see actually vincristine be more likely to do that. You get the hand glove distribution of neuropathies there. Which one comes from the periwinkle? Vincristine as well. We were actually joking about that yesterday. We were on back order and we were like, what are we going to do? Like go find a bunch of like pink periwinkles and just mash them up and give them to the patient? That's what you do sometimes. We don't do that. All right, going forward. Application of corticosteroids to which area would most likely lead to systemic effects? Say, for instance, if you had psoriasis and that was your username. Again, you don't have to disclose that kind of thing to everyone here. Would it be the soles of the feet, the forearms, the hands, or the axilla?
I didn't know the answer, so I think it's not going to matter when I get wrong.
What do we think? What's going to increase the absorption of these drugs leading to systemic effects? Again, some people dropped out perhaps, who knows. But again, so what law governed this? Fick's law, right? So what are the things that went into that? Surface area, good. The, what's that? Thickness of the actual barrier trying to cross there. So which one of these had the thinnest? That's allowing for the most flux. the axilla, right? So I also could say the face, I could say the genitalia. All those would be totally fine. Intertriginous areas for sure. All these other areas are much thicker than that. It'd be a much harder time for that to cross over. What other things would influence flux across those membranes? Concentration, yes. Permeability of the drug itself. So the more lipophilic it is, the easier time it has to go across, right? Also think about the hydration of the skin. Usually the more hydrated it is, the easier these drugs can cross over. It's real dry and scaly. It may make it more difficult as well. All right. Which of the following medications have mortality benefits in CHF patients? So lisinopril, enalapril, irbesartan, or candesartan. Which one of these have mortality benefits? No one should have a problem getting this one right. Should be obvious to all involved. All right, going forward. I don't know where all the people have dropped off. There's got to be more than 47 of you in the room, right?
I think his mic is off.
Is it off? Oh my goodness. Battery might have gone out. I'll talk extra loud. How about that? They're all correct. So everyone should have gotten it right. Why people don't like irbesartan? Jeez. Yeah, any of the ACE inhibitors, ARBs, they all have proven mortality benefits in CHF. Why do they do that? They help prevent the remodeling of the left ventricle. Again, all those other ancillary effects of helping to inhibit that RAS system are all going to be beneficial for those patients, right? What other agent should a CHF patient be on, potentially? Beta blocker, which ones?
Third gen.
Which ones? Carvedilol,
Oh, sorry.
metoprolol, which one specifically? The tartrate or succinate? Succinate, right? Is that the long-acting or short-acting? Long-acting, right? Think about the hard candy. Suck on it for a while, it lasts longer, right? And what's the other one? Bisoprolol would be the third one. That was the three main ones we use for CHF for the mortality benefits, right? What other drugs should those patients be on potentially? We mentioned beta blocker. Probably a statin, yeah. So they probably need to be on a statin as well, again, because again they have evidence of cardiovascular disease, right? Anything else? Okay, so diuretics, do those have any mortality benefits? Do any of them? Spironolactone actually might, right? So, and aldosterone antagonists, they have grade 3 or 4 heart failure, they actually do provide some benefit for those patients, right? However, what were the reasons why you should not take spironolactone if you have CHF? If your potassium is too high, and what else? If your creatinine is too high, because again, if your creatinine is high, that usually means what about their potassium? They can't process it well because they have poor kidney function unless their potassiums are elevated, right? Poor kidney function, you usually see hyperkalemia associated with that. So those patients would not receive spironolactone, even though it could maybe provide some benefit. The risks are too high at that point. Very good. Why are some chemo regimens considered to be count dependent? There need to be a sufficient cancer cells for the chemo to work. Hospitals need to wait for enough patients' appointments to make a profit. Tests for neuro impairment, having a patient count to 100, or the patient's immune system needs time to recover. Or is it a Count Dracula issue? What do we think? All right. Yes, the patient's immune system needs time to recover, right? So I'll give you an instance of this, how it actually worked out for us yesterday. So we have several patients coming into our infusion center for their chemo regimens, right? And so one of the big things that we had to check for, so normally, for instance, like, making chemo, do you think it's like more or less labor intensive than, say, making like regular medications? More so. Why do you think so? I hear radioactive. We don't handle the radioactive stuff, right? So usually find some other department will handle that. We find that they are hazardous though, for sure, right? Because what can they cause in normal, healthy people? They can cause cancer, right? So again, this is a big reason why it's important that we make sure that we do not expose anyone else to these drugs other than the intended patient to it. So it's pretty labor intensive. So we used to make all of the vincristines beforehand because it was the most common medication we probably give for a lot of those leukemia kids. And so we would always just make the vincristine just the night before, so that way it's ready to go. That way, because the morning's usually pretty busy with surgery and other things. But because of the shortage, now we're having to wait for these patients to actually make counts, right? So what would we wait for? We'd wait for their, what counts specifically were we looking for in the CBC? So absolute neutrophil count and platelets, right? So we look for those two, and once the nurses said, okay, the results are back, they're high enough, now we go ahead and give this. Another instance is actually a patient was on what they call an escalating methotrexate dose, where based on a regimen they would get a certain dose, and then they come back the next time, get a higher dose and a higher dose and a higher dose, and that was also based on count. So we'd have it so where if they were above a certain level, they'd go ahead and get a higher dose. If they were below a certain level, they'd either get the same dose or nothing at all, right? So some of it is having to do with giving the time for the immune system to recover itself, okay? Because if their neutrophil count is undetectable, what does that put them at risk for? Infection, right? How about if their platelet count's low? Bleeding, absolutely, good. Which test should be ordered before starting tazarotene in a 26-year-old female? Should be LFTs, a CBC, a urine drug screen, or a urine HCG. Now she just got back from spring break, what do I check? Urine drug screen. Make sure they're not doing too much partying. All right, moving forward. Yes, a urine HCG. What does HCG stand for? Human chorionic gonadotropin, or human cat goat, depending on. No. Yes, human chorionic gonadotropin. What does that tell you? Is she pregnant? Yeah. So would I want a urine or blood potentially? Urine's fine, right? It's easier. I don't have to stick the patient. Urine's totally fine. But you could also check the blood too, right? You could do both. Now, why would I check a urine HCG for this patient? Because it's potentially teratogenic, because it's what class of drugs? A retinoid, right? So similar to tretinoin, similar to Accutane, or what's the generic? I said tretinoin, thank you. So similar to that, again, you do worry about the teratogenicity of it, right? So you want to be careful with that. When would you check a urine drug screen? No, I wouldn't do that. That'd be mean. I want to blow up their spot. I want to narc out on them. So some, maybe before I give a beta blocker, if they have cocaine on their list, maybe. No. Usually, sometimes what we can do is have like patients on like chronic pain management. Sometimes we'll actually check them to see if they're positive for opioids. If they're not, then they could be selling it potentially, right? So there's some other causes we might use urine drug screens for patients, but this would not be one of them. Okay. Very good. Let's see, moving forward. Which medication is appropriate for an acute asthma exacerbation? It would be montelukast, ipratropium, salmeterol, or fluticasone. Once again, you're saying, wait a second, my go-to drug's not there. What do I do? All right, moving forward. It's actually going to be ipratropium. Very good. So montelukast is what kind of drug? Leukotriene receptor antagonist. Is good for long-term, short-term management? Long-term, right? This is sort of a scheduled medication in the beginning at nighttime, typically. Scheduled long-term care, right? How about fluticasone? What class of drug is that?
Corticosteroid.
It's a corticosteroid. Is it inhaled, systemic?
Probably.
Inhaled, right? What were the main like parenteral or systemic ones we talked about? Dexamethasone, prednisone, methylprednisolone, prednisolone. Those are the main systemic ones you're going to find, right? How about salmeterol? What kind of drug is that? The long-acting beta agonist is not good for acute asthma exacerbations, right? However, we do have ipratropium, which is what kind of drug? Anticholinergic. Is it antimuscarinic or nicotinic? Antimuscarinic. Remember, you see bronchoconstriction when you have muscarinic activation. Remember, what was the mnemonic we used for cholinergic activation? That's anticholinergic. So you were not blind as a bat, not hot as a hair. No, doesn't count. There's a whole mnemonic we had for it. It was the dumbbells. Remember that? Talked about that briefly. Let's go through it so we can all refresh ourselves. What was the D? Defecation. What was the U? Urination. How about the M? Well, everyone's mouth is all sewed shut at the same time. Mydriasis or meiosis? Meiosis, right? Anticholinergics cause mydriasis, right? Think about rest and digest. Do you need a lot of light coming into your eyes if you're just sitting there vegging out digesting? No. All right, they get miotic, okay? Remember we had some drugs that cause that in ophthalmology, like carbachol, things like pilocarpine, okay? So we got the meiosis. How about the bees? Call those the killer bees. Bradycardia, very good. What else? Bronchorrhea, and you're getting secretions everywhere, and bronchospasm, okay? So cholinergic activation. Remember there's a drug called methacholine you can actually give to stimulate an asthma exacerbation to make the diagnosis, right? It's cholinergic agonist, so ipratropium would be the opposite of that. Okay, so we got the B's. What else? You got E. What's E stand for? Emesis, right? They're going to be vomiting quite a bit. L. Lacrimation, crying, and then S. Salivation, right? They're going to be just having fluid coming out of every single orifice possible, right? It's very, very gross. You ever see like a patient who gets like exposed to organophosphate, something like that? It can be very, very, it gets wet, right? Because again, there's just fluids everywhere. They'll have, liters of fluid coming out of their Foley catheter. They'll have diarrhea. They'll be vomiting. It's a whole thing, right? So, and how would I treat that potentially? It's an anticholinergic I could give systemically. Atropine would be a good drug for that, right? So atropine can be used to reverse a lot of those effects. But in the lungs specifically, I can use ipratropium, and that's going to help relieve that cholinergic activity, okay? Very good. All right, up next, which of the following medications is it safe to smoke with? We'll say cigarettes, to be specific. Would it be bupropion, nicotine gum, albuterol, or varenicline? Moving forward, let's see what we think. There were 3 correct answers. Very good. Except for 9 of you. 9 of you were mistaken. That's okay. Let's talk about it. So, starting out with, why is it safe to consume with nicotine, with smoking, right? So nicotine gum itself is nicotine. It's going to do the same things as cigarettes are. So what are you going to see? More toxicity, right? You're going to see nausea, vomiting, you can see CNS effects. It's not great, right? So again, you would not want to top those 2 together because then they're getting more than what they were probably getting at baseline, right? So you wouldn't want to do that. Bupropion, how does that work? How does it work for addiction specifically? Works with dopamine, right? So it helps to kind of dysregulate that dopamine system, that whole reward pathway that nicotine is stimulating, causes that addiction. Bupropion can be used to kind of help to reset that, so to speak. And so that dopamine is going to be helping to fix that problem there. So that would be okay to smoke with because, again, they don't interact with one another specifically. How about varenicline? How does that work? What's the main side effect of varenicline? Yeah, you guys remember that stuff. It's crazy dreams, but what's the mechanism? What does it do? It's a partial nicotine agonist, right? Why do we care about that? What does that do for us? Prevents withdrawal symptoms, right? That's why we give them nicotine, because it's replacing what they're missing from the smoking, and then we gently wean them down, right? So vareniclin's a partial agonist. Why is it okay to smoke with that, though? The receptors are already occupied by the vareniclin. If you start smoking on top of that, it's okay because those receptors are occupied. Don't get any additional benefit because the vareniclin's only partially agonizing those receptors. So remember, when do you start vareniclin? A week before their quit date. So they're still smoking. They'll have the medication on board. The idea is to kind of gently transition them off of the cigarettes onto just the medication to help stave off those withdrawals. Okay? Make sense? You can remember the crazy dreams. Oftentimes that can be a reason to stop the medication altogether for some people. Okay? Very good. Which of the following is not a common side effect of methotrexate? It's a negative question. I usually won't ask on the test, but here it's okay. Let's see, hirsutism, renal dysfunction, leukopenia, or diarrhea. It's only kind of right.
Really?
Mm-hmm. It's like during interviews, they're always like, "That's a really good question." I was like, "I don't ask bad ones." And they get kind of thrown off a bit.
That count answer, by the way, the count up to 100 the neuro check,
Yeah.
that was funny. No one appreciated it.
Mm.
So the person who answered it.
All right, very good. Yes. So let's think about this. So why do we see toxicity from these cancer drugs? What kind of cells do they target? Rapidly dividing cells, right? So the fast dividing ones, where do we see a lot of fast dividing cells? In the hair, right? So you see alopecia potentially, not hirsutism, right? What about in terms of the diarrhea? Like, why do we see that? You're killing off a lot of those rapidly dividing GI epithelial cells, right? You're just sloughing a lot of those off, which is why you can see the diarrhea. Which cancer drug was really bad for causing diarrhea? Did you see I posted Chemo Man? You guys see him? Yep, he's available for you to check out. Irinotecan is really bad for that, right? 5-FU is also pretty bad, but irinotecan is really bad because it helps to do what? That inhibits cholinesterase, increasing acetylcholine levels, increasing muscarinic activation, leading to the dumbbells, right? Remember? So diarrhea is the very first one on there. So irinotecan does that quite a bit. How about leukopenia? Absolutely, you're going to see that, right? Because again, the white cells are definitely going to be taking a hit. That's a big reason why we would not give any more drug until they let those counts recover, specifically the neutrophils. Okay. Very good. Which medication provides mortality benefit in CHF patients? This seems like a duplicate, is it? Or did I already give away the answer potentially? Most likely. Let's go to different diuretics then. So hydrochlorothiazide, furosemide, acetazolamide, and spironolactone. All right. Yes, very good. It was spironolactone. Mostly because I already told you that, right? But we already mentioned the contraindications when you would not want to use that. Now, when would you use, say, like furosemide? Is it used often in CHF patients? Right? What's it used for? Get rid of the fluid. Now, that could potentially decrease hospitalizations, especially if they don't have a whole lot of fluid backing up into the lungs, but there's no proven mortality, at least in the studies that they've done. So we would not use that for specifically those benefits. However, if they are watching their weight and it's going up by a couple pounds every day, that's probably fluid for those patients, as they can take their Lasix, their water pill, so to speak, and get rid of that extra volume, right? Hydrochlorothiazide would be likely used for what purpose in those patients? More likely for hypertension management more than anything else. It can have some extra synergy with Lasix, but again, in terms of diuresis, what's the most powerful ones we got? the loops, right? So thiazide is not going to be quite as powerful as that. And then acetazolamide, would we ever use those in a CHF patient? Unlikely, right? Unless maybe they're going to Peru, go hiking, although they probably won't get very far because they have CHF, so who knows. But again, that's one is going to be working where? Where does acetazolamide work? Proximal convoluted tubule, so it's kind of the wimpiest out of the diuretics, right? Okay. After failing OTC benzoyl peroxide, which medication would be indicated next for just facial acne? We go with hydrocortisone, we go with lithium, doxycycline, or adapalene. Does anyone know where lithium used to be found in, say, the grocery store? 7-Up. It actually used to be the lithiated soda. It would uplift your mood. Get your answers in. All right, it's actually going to be adapalene. Very interesting. So, a little bit of controversy here. Let's see what we can do. So, again, what has the patient only tried so far? Just over-the-counter benzoyl peroxide. So, do we necessarily have to jump to using an oral antibiotic?
No.
Not necessarily, right? So, unless it was a little bit more diffuse or maybe severe, maybe you'd want to go ahead and start at that point. But I think for most patients, starting off with another topical agent seems reasonable, right? And so, which one would be a good option here? It would be adapalene, and that is what class of drug? Another retinoid, right? So topical retinoids are going to be okay to go with at that point. Tretinoin would be fine, and it would be reasonable there. Lithium, why did I put lithium here? Yeah, it can cause drug-induced acne, right? So I just mentioned that. How about hydrocortisone? It's a steroid that could potentially cause it, but more than likely maybe used for more like inflammatory disease, but certainly not for acne in a lot of cases. Okay. Yes, sir.
Does the different is that one specifically inactivated benzoyl, or is that's another one?
It was tretinoin that the benzoyl peroxide inactivated the tretinoin. That one's more resistant,
Okay,
right?
but not this one.
Yeah, adapalene's more resistant. Sunlight does not inactivate it. Yeah.
That makes a lot of sense.
Yeah. What do you recommend for patients when they're going on topical retinoid? Stay out of the sun, or if they're going to go into the sun, use good sunscreen, right? A physical blocker, not just a chemical blocker. Something that's actually going to provide some actual blocking of all those UV rays, right? All right. Okay, which antiarrhythmic association is correct? Would it be class 3 in magnesium, class 4 nicardipine, class 1B in lidocaine, or class 2 dofetilide? I've already given this one away, but it was a while ago, so hopefully everyone's forgotten. Or you just know it because you just know it. All right, let's see. Very good. Most people got 1B in lidocaine. What would go into the 1C category? Propafenone and flecainide. How about class 1A? What's the mnemonic? PDQ, right? So we have, what's P? Procainamide. Quinidine's the Q, and the D is? Disopyramide, right? What was the problem with procainamide potentially? Say you have a patient and they have a slow acetylator. They come in with, yeah, drug-induced lupus, right? So procainamide is actually more common than, what other drug do we talk about that causes that? I think it's more common than hydralazine actually, but we don't use it as frequently. How about magnesium? What class does that fit into? Kind of like miscellaneous. It doesn't really fit a category specifically, but we know what we use that for. Odds, very good. How about class 4 nicardipine? Why is that wrong? It's a calcium channel blocker, but we need a non-DHP here. So verapamil and diltiazem fit the bill. Yeah, so it's not even antiarrhythmic, right? If anything, what arrhythmia could it cause? Nicardipine. It's actually sinus tach, right? Because remember, it's a vasodilator, so if it causes the vessels to open up, that causes the heart rate to go up usually. So that can just cause sinus tach. And then dofetilide, what class? 3, right? It's a potassium channel blocker. What is our class 2 agents? Beta blockers. Very good. All right, getting close to the end. For arrhythmias, flecainide are considered. In this case, would it be rhythm or rate control? Again, I've given away a lot of these answers already, so you're lucky.
Good job.
This would be very good. Rhythm control, right? Because those 1Cs will be able to actually convert them back to a normal sinus. It doesn't do anything specifically for the rate in terms of slowing down nodal conduction like a beta blocker or a non-DHP would, right? Very good. 2 more questions. Which controller medication is used in COPD but not asthma? Be albuterol, ipratropium, beclomethasone, or tiotropium. Used in COPD but not asthma. Right, moving on. Very good. Yes, tiotropium or Spiriva. What class of drug is that? It's a long-acting anticholinergic, right? Spiriva is a long-acting anticholinergic. It's only used for COPD, right? So it's kind of like the cousin to ipratropium, which is a short-acting anticholinergic, right? So that one's only used in COPD. We don't really see a lot of benefit for asthmatic patients, right? Beclomethasone is what class of drug? It's an inhaled steroid, very good. And we know albuterol certainly and potentially ipratropium is used for those COPD patients as well, right? All right, and our last question. Which of the following agents is cell cycle specific? Oh boy, in with a barn burner. Carmustine, temozolomide, vinblastine, or cyclophosphamide? Some of you are like, what's a cell cycle?
If that's right, I'm going to use it as a yeah, it's fine.
All right, let's see what we got here. Is ooh. I know this thing's little. That's okay. Let's talk through it. So, looking at these, remember we have cell cycle specific agents which work on a specific part of the cell cycle, and then we have the ones that are non-cell cycle specific. Broadly speaking, which ones are non-cell cycle specific? The alkylating agents are one of the big ones, right? So actually all 3 of these, carmustine, temozolomide, and cyclophosphamide, are all alkylating agents. They work on any part of the cell cycle. It doesn't really matter. And they are also tend to be much more toxic as a result of that, right? A lot more alopecia, a lot more, I think, like pulmonary fibrosis. They're pretty nasty in terms of the drugs there. However, vinblastine works where? On mitosis, right? So it only works on mitosis. So it only works on the cells undergoing mitosis, which are a lot of those cancerous cells. That is again why it's going to be very specific for that particular part of the cell cycle. Now, the reason why a lot of you probably pick cyclophosphamide is because you're probably thinking of cytarabine or Aracept. Now it goes to show you that drugs look and sound alike, and guess what can happen? You can get screwed up, right? You can pick the wrong ones. So, again, what a great moment in learning. See how many points I can illustrate to you without even trying, and just by putting up the right wrong answer on there. Anyway, okay, so that's it for this review. The winner is Mimsy. Mimsy, who's Mimsy? Can you identify yourself? No, the winner will identify. Very good, thank you. Get your free answer, Chiz. Actually, A this time, so. Who's Nostatin? Very good for in second place, and very nice. Very good job. Good job completing the last review. So, let me check the board really quick. 1 second, guys. No questions up here. Please review the stuff. Ask me questions. The test is on Monday. Be prepared. I won't be here, but of course I'll be here in spirit. Any questions before you go? Huh? I don't know. We'll see. Thank you for a wonderful class. Please provide. Well, we still got epi bios. And farm 2 is twice as long, so like you're not getting rid of me, trust me. But please like take the time to do those reviews. Like we really do look at those, and I really do take the class only gets better because of the reviews you provide. And go again, farm 2 is more of farm 1. So let me know how I can improve the class, make it better for you, right? So please do those. I appreciate that. If nothing else, I will see you next time.